Hello, everybody, and welcome back. It's lovely to have good morning, afternoon, evening, wherever you are. And I hope that you've been enjoying the conference so far. I'm Janine Austin, and I have the honour of chairing this session. It's going to be moderated by Anna Middleton, who's going to be dark screen today. But yeah, this is the last primary session before the end of the conference, actually. And it's about leaders in genetic counselling. It's case studies and stories of leadership. So I'm really looking forward to hearing what our speakers have to say. And so today's treat of a lineup for you is Lara Gaff. We then follow her presentation with Charlotte Malmgren and Rebecca Pestoff. Following that will be Maya Thangavelu and then Sagira Malik Sharif to round us out. And so please remember to use the Q&A box in the platform as we go so that we can pose your questions to the speakers at the end. And then remember as well, you can join us all in the spatial lounge afterwards. With that, I'm going to turn over to our first speaker, Lara Gaff.
Firstly, I'd like to begin by acknowledging the traditional owners and custodians of the land on which I am today, the Wurundjeri people of the Kulin Nation, and I'd like to pay my respects to their elders past, present and emerging. I extend that respect to any Aboriginal and Torres Strait Islander peoples at this meeting today. Thank you very much for the invitation to speak. It's really a pleasure to participate again in this World Congress of Genetic Counselling, and particularly to talk on this topic. I lead a government-funded program to get genomics into healthcare. So talking to governments is a key part of my role, navigating between genetic counselling, genetic services, and governments. Talking to governments sounds like an important thing to do, and it is. I'm attempting to influence the directions that a government is taking. It also sounds very dry and possibly quite boring, but my guess is that there would be very few of you, genetic counsellors or in professional bodies, that would think your situation is perfect with respect to genetic counselling and health services, and that there's no change needed in areas that your government is responsible for. Those kind of areas can include regulation of health professionals, protection of privacy for clients, protection from discrimination, health service priority setting, health system planning and delivery, allocation of resources such as budget are all very relevant. So I'm going to talk about some of my experiences in this area. And just to set the scene a little bit, in Australia we have 7 governments. So as well as the national government, Australian government, which is responsible for regulating health professionals, for example, there are state governments. Most of my work has been with state government. I'm in this little green one down the bottom, Victoria, who, as the state governments are responsible for delivery of hospital services, and that includes genetic services. So I recognise that the responsibilities and the structures and systems of government differ greatly around the world. So the governments of all the people attending this will be quite different. But my aim in this talk is really to be as widely applicable as I can be. And I'd be really interested to hear what others think, what people have experienced in common or where they think differences might be. So this is really less of a how-to guide, though I give some tips, but maybe something more about raising awareness and perhaps even a call to action. So first of all, in talking to governments, it's important to know who has influence and to distinguish between government, that is the body of politicians, and in our system in Australia, they're elected to represent the people. But public servants, commonly referred to as government as well, but actually they're key players, but in our system, they're employed and not elected. So they're relevant for this talk as they work in government departments, or many work in government departments, and they have a range of roles relating to policy advice, development and delivery of public programs. And often they're a key connector into government. So in this talk, I am going to mostly focus on talking with government about funding, because over the past 3 years, that's been my main job, securing funding from the Victorian state government for the genomics program that I lead. The first tranche of funding was actually an election promise. I literally woke up one morning to this headline in the most widely read newspaper, and within half an hour, both of the main parties had pledged a 4-year program of $25 million to Melbourne Genomics if they were elected. And so with that funding secured incredibly easily, and still amazes me, it was a matter of working out with government and with the department what the key changes and program would be. The government wanted to know the ways in which genomics could make a difference to patients in Victoria within the participating hospitals, what changes in care could arise, and what health savings there might be. We were very successful in doing that over 4 years, but having the evidence isn't the same as that change then being spread throughout our health system. So 4 years later, when our funding was starting to run out, we developed a business case for $35 million worth funding. That's Australian dollars, about 22 million euro, 26 million US, 19 million pounds in today's conversion rates, and asked for funding to work on embedding change in the health system. Now, I was incredibly naive when we submitted this. It was put to the Department of Health and the Minister for Health, and I sat back and waited to hear the results. It was an election year and they were funding largely election promises, and we'd already been an election promise. It wasn't particularly attractive to government, but I also think that even if it hadn't been, I don't think we would have been successful. What I failed to understand is they're long documents. They need many levels of approval and often refusal. So the next time round, a year later, we developed a new business case, and this time we did things very differently. I made sure that the proposal was very clear about how it would support government to deliver on their priorities and their promises. And I worked with others to make sure that the key people understood. That meant lots and lots of meetings over the course of a year. And it kills me not to give you a blow-by-blow account of those, because there were so many and it was so important. But what I'm going to do is just give you some of the key moments and key things that helped make change. So the first one was a breakthrough meeting. This was game-changing. There were 2 moments that were game-changing, and this was one of them. Professor Sue Hill and Ellen Graham from the NHS, are responsible for implementing genomics in the NHS in England, came to Melbourne, and we met with the Minister for Health. This meeting was at Parliament House. It was a sitting day, so she was running late. She'd come out of the House, Parliament House, into a meeting room. There were bells ringing to make sure that MPs were back for votes. It felt kind of very not calm and a bit chaotic. But Sue was amazing. She really knows how to talk the same language as politicians. And she spoke about the potential impact of genomics on health and the budget in a way that politicians understood. You could see the Minister of Health's eyes light up. And it was that meeting that won her our support. And you know it's been a good meeting when the Minister, even though she's got to get back in to vote, insists on taking a photo with you in Parliament House and tweeting it instantly. But the Minister for Health support is not enough. Government decisions are made at a higher level, again, by a small committee of key ministers. But what was crucial was the Minister could open doors for us. She helped us and her for us to advocate for this proposal. It's easy to ignore an email requesting a meeting from me. It's much harder to do that, or it carries a lot more weight when a health minister is emailing another minister to suggest meeting us. So we could be helpful to her by helping us, by making the case with her colleagues. As a result, I had many meetings with the Premier's office and with ministers in relevant portfolios. Largely, those meetings were actually with the advisors. These are not public servants. They're employed by ministers and they know the minister's interests. They act in the minister's interests. They get the lay of the land and identify what's relevant. They're very influential and they are, without exception, on the ball and engaged. I always came away from these meetings feeling positive. I also always asked who else I should speak to. There's a lot of etiquette about who's allowed to talk to who, and they opened doors to public servants, and those were very different conversations. These are the employed public servants, more detail-oriented and cautious. I think they saw their job as making sure we had realistic expectations of our chances of funding, which they saw as low, and I came away from those meetings feeling very pessimistic. They were all critical. This is the government approval process, as I said, is long. And people across many departments and offices need to be familiar with this, with our proposal to make it sure it's successful. Effectively, the 110-page proposal by the end of that process is winnowed down to one line on a very large spreadsheet. And it's not enough to convey. You need people at that meeting who already are familiar and supportive of it. So the messages are also important, not only in meetings. I learned about the importance of an exec summary. I always thought this was just a summary of what was in the business case, kind of, like an abstract, taking out key points. We got really good advice from experts about what those messages needed to be, and it was structured differently, like a narrative to convey why this proposal was needed, what the problem was, how we could help solve it, how this would help government with their agenda and goals. And we used case studies and very much tailored to government priorities. So it had a real impact for those many people, most people who were not going to read the business case at all. And it was also a very good calling card and something we could send after meetings. There are always challenges of convincing people. Change always in government. There's constant change in who's in what positions, who the ministers are, and you have to keep adapting to that. In our case, this process, COVID happened. Australia, it hit Australia, and the budget was delayed. In fact, the budget was delayed several times, and then the health minister resigned. So I'm saying this because when working and talking with governments, you need to stay resilient and adapt, and also recognise that priorities change, sometimes quite quickly. Oh, sorry, I'm just going to put that there. So you need to stay resilient and adapt to the changing environment around you and to the different priorities. We developed an addendum to our business case to point out why it was still relevant to fund our work, why it was still relevant, and how it could help the government with their new priorities and issues faced. This process also showed the benefit of the relationships, as in all the movement of ministers and advisors. Advisors that we'd met with in one portfolio then became critical in another portfolio and were already across our proposal. So finally, 6 months later, it seemed like an eternity after the original, and we were supposed to find out originally whether we were funded, was that we were successful. And not only that, we got every dollar that we asked for, which was really, truly extraordinary last year with the budget concerns and impact of COVID. We have a new change. We've actually moved out of the Department of Health, and we're now being administered by our jobs precincts and regions. That is the government's economic agency. I say this because different portfolios have different priorities and different interests, and also different departments have different cultures. And so again, understanding and working with those and getting a sense of what that culture is and what the priorities are is really important. So now we're working in a different way, this department, and there are some commonalities, like ensuring the minister has profile, and which is a great way also of showcasing our work and ensuring it has impact. So the feeling for me of this was a bit like being that ball in a maze. You know those little mazes where you sort of move the maze around, try and get the ball in the right position. I'm not quite sure. Sometimes I felt like I was holding the maze, and sometimes I felt like I was the ball. Anna said to me, talk about what it's like to talk to governments about genetic counsellors and genetic counselling. And not once did I explain actually what a genetic counsellor was or what genetic counselling is. I'm fortunate that our state government has appreciated for quite a long time now the value of genetic counsellors and genetic counselling. What I did do was always introduce myself as a genetic counsellor and lived the profession effectively in the leadership through living the values of genetic counselling, and through the way that the profession and my values as a genetic counsellor have been included or influenced the way our program has been developed. And I think that, well, not stated always, has definitely resonated with governments, and particularly the Department of Health. So when I started writing this talk, I was a little bit smug because I didn't need to talk about genetic counselling anymore. And then literally last business day, in fact, I was part of a professional group meeting with the National Department of Health on reimbursement for genetic counsellors who are providing services not funded by state government. This is work very much in its early days, and it builds on the work of genetic counselling leaders in Australia like Alison McEwen, Australia and New Zealand, Alison McEwen, Amy Pern, Laura Yates, Marianne Young, and many others who have progressively progressed recognition and regulation of the profession. And so what we're doing now is navigating new government processes that are themselves in the midst of change, with people still quite focused on COVID and vaccination, but also putting in new processes to review funding arrangements broadly. And we're hoping that we'll be part of this. Ironically, after many years working on mainstreaming genomics and making sure that genomics becomes part of regular health practice, one of the barriers to this now potentially is a view that everyone will be doing genetic counselling. And so we have to make the case of why fund genetic counsellors when there are already funding for medical practitioners, funds for medical practitioners to do this work. We need to do that in a way that is supportive, and working with our medical colleagues whose support for us will be really critical. And I think that probably equity of access will be a key argument here. So it's in its early days, but the leadership in this area from the Human Genomics Society of Australasia is good. And there's a supportive group, an experienced group behind that, helping behind the scenes. And I think that this is really important too. From my time working in government, I could see sometimes that there were people that were really passionate about what they were doing, and they would sort of ping all over the place, talking to lots of people, but not in a structured, thought through way. And there'd be multiple people sometimes talking to these different people. And so there was no necessarily one key point of contact, and cohesion, a cohesive message, cohesive working, and a coordinated way of doing this is really important. So just some final thoughts on what works. Understanding policy priorities, having clear messages and putting them first, not second. We normally make the case and then say, here's my message, do it the other way around. Using case studies, patient case studies, always backed up by evidence and numbers. Identify and meet key politicians and public services, build the relationships and maintain them. Get good advice, professional advice, people that are expert in doing this and working with governments. As I said, be organised and cohesive, and take people on the journey with you. I think with the reimbursement area, we have membership that are very keen and have this as a high priority. I think we'll have to manage their expectations around timelines and what can be achieved as well. So I see my role as one that links those working in genomics and genetic services and genetic counselling with government, not the only link, but one of those links. I want to make sure that this works for the genomics community, and I see that this also needs to work for the benefit of the people who are funding that. And that is actually taxpayers who have elected the Victorian government or federal government. I have had no training in how to do this, so I'm mentoring, but I've found that the genetic counselling skills that I have been incredibly useful. Genetic counsellors are used to listening, to understand what is important, to gathering information and building relationships. We are used to conveying complex ideas and concepts simply, so they're understood and they have impact. We're used to working with clients, and in this case, the government rather than patient clients, to achieve goals, their goals and ours. And we're used to not following a formula. We might have a general framework or approach, but we're also used to adjusting to changing information or circumstances. I know there are many other genetic counsellors with experience of working in policy and with governments. I thought Michelle Bishop gave just a lovely talk a couple of years ago at this meeting, and I'd really encourage people who are interested to go back and look at her article in the special issue talking about this. I'd also be interested to talk with other people about their experiences. But most of all, I'd like to encourage people that maybe have not ventured into this area to think about signing up to a group with your professional body to do work that will give you some experience in doing this. Don't just randomly go off and decide, right, I'm going to advocate for this, but work with your professional body or your organisation. And finally, all of us in just genetic counsellors through our professional body, but also through our organisational allegiances and employers, have the opportunity to affect policy and decision making within our organisations. And that can be a really good training ground for then doing it within the health system and with governments. So I am looking forward to hearing other people's experiences and stories of leadership. And I hope that this has stimulated some of you to think about doing more in this area. And I'm very happy to talk to anybody who is interested. Thank you.
Hi, my name is Charlotta Ingvaldstad Malmgren. I'm a genetic counselor from Sweden, and I'm presenting this with Rebecca Pestov, who is also genetic counseling in Sweden. As you all know, genetic counseling is an emerging profession in the world, and so also in Sweden. And here in this talk, we would like to talk about our journey, how we have tried to implement the role and definition of genetic counselors in Sweden. We have been working with this project or road for about 20 years. So during these many years of the development of the genetic counseling profession in Sweden, it has been both ups and downs. But that's a little bit what it is to start a work on a long journey. And as one of my big mentors within the genetic counseling community, Heather Skirton, once said to me when I was visiting her, she said to me that is what it is to be a pioneer. It is 2 steps forward and 1 step backwards. I would say that this journey has been a long and winding road. And this is a talk from me and Rebecca. So it's a talk for us as the chairs for genetic counseling in Sweden, the Swedish Society of Genetic Counselling, but it will also be a slight personal journey, what has happened from our point of view. Of course, there have been other people in Sweden involved in the development of the role of genetic counselors, but this is from our view. In the early 20s, there were 2 programs for genetic counseling students in Sweden, one at the University of Gothenburg and one at Uppsala University. And both those programs were 2-year part-time programs corresponding to a 1-year full-time program. And the programs were running for a few years. When the Bologna process were being discussed in Sweden, and we wanted the programs to become master programs, 2-year programs, there were no university at that time that were willing to take on that program. And I think it's because we're a very small country. And at that time, there weren't really enough need for genetic counselors working corresponding to the need of number of students to have a master program. Anyway, we were a few students. We were about 20 students in Uppsala in my course, and I will talk about my course. It was the first course in Uppsala, and when we were taking our degree, we were really excited. Many of us were really waiting to have an employment as genetic counseling, starting to work with this fine skills that we have learned. But at that time, there were very few employments as genetic counselors in Sweden. So many of us had other type of works instead, and we wanted to know why was that. And I think it was a little bit about the timing. It was a little bit too early for the role of genetic counselors. There were no big demand of genetic counselors working within the clinics. And it was also slight little knowledge about the profession among other healthcare professionals, but also among public and patients. Further, the role were not really defined. What could a genetic counselor add to the clinic and to the clinical work, and how could we work together? And I think that, together with an already set hierarchy between different professional groups, led till there was no or very little trust in the profession, not in the person that was having the profession genetic counselor, but they didn't know so much. There was little trust from other healthcare professionals. And that led to the discrepancy between what the students coming out through the programs, what they wanted, what they had expected, and what was really there and what was clinically relevant and reality. There was no, which it's still not, a professional title, or it's not a protected title anyway. So that's something else that was a problem. So from this base or this knowledge, we tried to focus on some aims that we wanted to achieve with the genetic counseling profession in Sweden. So first of all, we wanted to increase awareness of genetic counseling in Sweden. We also wanted to improve the access to genetic counseling to all patients in Sweden. We know that there are too few resources to meet the patient's need today for genetic counseling. We also wanted to achieve patient safety by having a quality assessment of the genetic counseling profession. And as we didn't have a master program, we wanted to implement and improve other educational pathways in Sweden. In 2007, we started the Swedish Society for Genetic Counselors, and I was the founder and the chair for the first almost 20 years, about almost 15 years in this society. And we have done a lot of work together. And I met Rebecca a few years after the society started. And since then, we have worked very closely together to establish the genetic counseling profession. So when we started this genetic counseling society, we were very much a standalone society. We were not really part of the Swedish Society for Medical Genetics. We were not really working close together, and we were not part of the clinical genetics meetings in Sweden, for example. But in 2010, the ESHG asked for a representative of the genetic counselors in the ESHG, and from there we became in 2011 an ordinary representation within the board for the Swedish Society of Medical Genetics. And now we are not, even if we also standalone organization, we're really part of the Swedish Society of Medical Genetics. From 2013 and 2016, we had a great work together with the international colleagues to work on the definition of genetic counseling, the curricula of educational programs for genetic counseling, and the role of genetic counseling, both in Europe, but also in Sweden. And that led to a number of publications that we have been able to use in advocacy work for the genetic counseling process in Sweden. During those years, when those first programs didn't continue, we have tried to start other kind of courses and master programs. For example, we had an advanced level course in Uppsala University at 2012-2013, 15 credit course, and also in Lund University they have had a 15, they're still doing that course, 15 credit course. We also applied for a master program, a Nordic master program in 2010, where we actually didn't receive funding, but still we thought it might be a good idea, as all the countries in Scandinavia are quite small countries, and we could have done that together. So until now, there was no new master programs in genetic counseling. But to further more organize in a formal way the discussion and development of educational ways for genetic counselors in Sweden, Rebecca will tell us more about how we started a more formalized way on an educational group. And I will head over now to Rebecca, who will take the rest of the part of the talk.
Okay, thank you, Charlotta, for that. And I'll continue now on a straighter path forward. And in 2014, we started an educational group under the Swedish Society of Medical Genetics and Genomics, in which there was a subgroup for genetic counselors to work on educational routes and further progressing the profession. So we had meetings and workshops, and we developed an educational program or a professional progression program for genetic counselors in Sweden in 2014. And we continued the work with this professional progression, and in 2017 and even after that in 19, it's been revised a few times. However, the basis is the same, and that means that we start with a basic profession, whatever the person who is employed has, and it can be a nurse or a technician, a lab technician, a counselor, or a psychologist. And that background profession is what you're hired as. Then you fulfill different competencies and skills and responsibilities and continuing education. When you fulfill those requirements on that level, you then advance, in this case, to become an assistant genetic counselor. And again, the assistant genetic counselor goes into a program of gaining competencies and skills, increasing responsibilities, and continuing education to be able to advance to the next level of genetic counselor. And the time spent as an assistant genetic counselor before advancing is about 2 years, or if there's a master's program in genetic counseling, you are hired straightly as a genetic counselor. And for each level, there we have defined the different progression that you need to achieve to be able to move up. And the final level that we have defined is then being able to apply for a certification as a genetic counselor according to the Swedish Society of Medical Genetics developed program that we have done together. And this is part of the article that was published. I'll tell you more about that soon. In 2017 to 18, we worked a lot further on defining the role of genetic counselors. And we collaborated a lot with an international research group on this area, among others who you can see here. And we had a qualitative questionnaire survey that we gathered material from, and from many different countries in Europe. And the findings showed that both practical experiences in educational routes and multidisciplinary teamwork influences how the genetic counselors practice in different countries in Europe. And we also found that there was a complementariness between medical geneticists and genetic counselors. And we succeeded in showing the added value of genetic counselors working in clinical genetic services in many countries in Europe. And we were also, the coming years, lucky enough to be able to recruit some international speakers to our annual meeting at the Swedish Society of Medical Genetics and Genomics. Among others, well-renowned Ramona Moldovan, who spoke to us, both genetic counselors, clinical geneticists, and laboratory geneticists on the importance of psychiatric genetic counseling and that research area. And the following year, we were lucky enough to invite Christine Patch from the 100,000 Genome Project and inform us on that. As I said previously, the educational pathway resulted in a publication as well, because we did get a lot of interest, and we wanted to share this work that we'd done with other countries in a similar situation as ours. So we published a suggested educational program that we used in Sweden with a checklist of requirements and suggested learning outcomes. And this was done in collaboration with the Medical Genetics Society and our professional organization. And to further our opinion work, we in 2019 published in the National Medical Doctors paper the fact that genetic counselors want to have a genetic master's program in Sweden for genetic counseling. And we also there that year contributed to the well-renowned Addendum article about the global state of genetic counseling profession in the world. And then, as you know, came 2020, and we were stuck at home, and we had to stay away from meeting physically and further work in physical meetings. However, this gave us a lot of time to think and to work from our own home chambers together and via Zoom, of course, or digitally. And we got to get some other interests as well, like yoga and meditation, maybe. And finally, we had the relief of vaccinations. And again, this was just in time for the launch of the new master's program in genetic counseling that has started here in Sweden at Linköping's University this fall. And this program fulfills the EBMG criteria for accreditation, and an application is to be submitted in the summer. The first class of students has started, and there's 12 students from very varying backgrounds, a very interesting group, very motivated, and I hope some of them are here listening to the conference talks. The aim is for them to graduate in 2023, and this is a course given in Swedish. It's a hybrid model of mixing online learning for the theoretical parts and then having physical learning or in-house learning for the more practical parts. And there's also, of course, practical placements and a research project for those 120 ECTS credits. So we would like to leave you with some recommendations for other people or countries who might find themselves in a similar position as we have been in Sweden regarding the professional state of genetic counselors. And number one is to find the like-minded, like Charlotta and I did actually find that we had similar goals and aims when it came to genetic counseling. And we also have been finding many role models and mentors, both in Sweden among clinical geneticists and other professions, but also among many of our colleagues in the UK. So we also suggest that you have tried to achieve some national and international collaboration to inspire you and to give you ideas of how you can do things in your country. And as Lotta also mentioned previously, creating trust is very important to create a trust for you as a person, but also for the profession, the need for the profession. What can a genetic counselor provide? And we've been working a lot with that too. And importantly is to adapt to your context. Every country has a different healthcare system, political system, educational system, hierarchy. So it's important to take ideas and inspiration from other places and countries, but also to adapt it to your country to make it realistic. And we have continuously been doing a lot of advocacy work, both with patient representatives, patient organizations, but also within healthcare, other healthcare professionals, within the public realm, and also on the political level. We've been trying to do a lot of this kind of work, and with the union. So our recommendations is don't be afraid to be a pioneer, and really don't give up. And we thank you so much for listening to us. It was nice to be able to speak to you, and you see our contacts at the bottom of the slide if you have any questions, but there might be times for some questions now otherwise. Thank you very much.
I appreciate this opportunity to present my experience and view of genetic counseling in India. For this presentation, the past is the period between 1979 to 1981 and 2007 to 2015. The present is 2015 to 2021, and the future is 2021 onwards. In the early 1980s, I was back in cytogenetics, pursuing a PhD in clinical cytogenetics. To start with, the year was 1979, the place, the city of Chennai, in the state of Tamil Nadu in southern India. I was a newly minted graduate from the Genetic Counselling program at Sarah Lawrence College in New York. Like many trainees in genetic counseling, I was trained in an affiliated field in genetics. Before joining the training program at Sarah Lawrence, I was trained in clinical cytogenetics at the University of Aarhus in Denmark. After graduation from Sarah Lawrence, my mandate in India in 1979 was to set up and operate a cytogenetics lab at KJ Hospital, a private hospital in Chennai. The services of this lab were offered to patients at the Government Women and Children's Hospital in Chennai. Although I was functioning as a cytogeneticist, I had the opportunity to meet patients. This was my first exposure to patients with genetic disorders from the representative population of India in that era. 99% of the patients were from the Department of Gynecology, from the working class, and presenting with primary amenorrhea. This experience was my introduction to what genetic counseling would be like in India. As I was functioning in the capacity of a cytogeneticist, I did not offer counseling to the many patients diagnosed with Turner syndrome and even one family with 3 siblings with testicular feminization. My experience in India between 1979 and 1981 was the basis of my early impressions about genetic counseling in India. I soon realized that the socioeconomic structure of India is vastly different from that in the other countries, and using skills acquired in those countries would not be adequate to practice genetic counseling in India. Although the principles of genetic counseling are the same universally, the practical delivery of genetic counseling in India requires additional consideration. In 2007, I met Dr. Annie Hassan of Kamanini Hospital from Hyderabad, India, at the annual meeting of the American Society of Human Genetics in San Diego. We discussed the importance of genetic counseling in the management of patients and families with genetic disorders and the need to have training programs for genetic counselors in India. These discussions continued across the oceans between North America, where I was residing at that time, and India. Soon after our meeting in 2007, Annie Hassan started the first genetic counseling training program in India, modeled after the training programs in North America. This training program has been a success. The first batch graduated in 2008. In 2014, the Board of Genetic Counselling India was established, and the first certification exam was held in 2015. Establishment of the board and the certification process has helped in recognition of genetic counseling as a profession in India. Compared to the 1970s and the 1980s, in 2007, the technical advances in genetics had grown by leaps and bounds and had also arrived in India. While application of genetics in basic sciences had made significant strides in India, there was need for improvements in applying genetics in clinical settings. It was important to introduce professionals in the fields of basic sciences and clinical sciences to one another if patients were to benefit from what the field of genetics had to offer. Along with her colleagues, Annie was able to initiate, organize, and conduct annual conferences in genetics. The goal of the conferences was to bring together basic scientists, clinicians, and those interested in genetic counseling. The first conference of genetic and molecular diagnosis in modern medicine was held in 2008. These conferences that continue to be held annually have been a major achievement of the community of genetic counselors in India. Following establishment of the Board of Genetic Counselling in India, the annual conference is held by the board. The most recent conference was held in July of 2021, the theme being Genomics and Genetic Counseling, Value in Healthcare. Looking to the future, there are many aspects of genetic counseling that are unique to India that need attention. What has changed in India between 1979 and 2021? There is reduction in the prevalence of communicable diseases. More people have moved from the middle class, moved into the middle class. This is accompanied by increase in the number of families with disposable income who can afford diagnostics. There is migration of population from the rural to urban areas, giving access to services that were not available in rural areas. The population has more access to information, so there is a much better informed population. These changes will continue to increase and will be accompanied by increase in the need for genetic counseling. What has changed since 1979 for genetic counseling in India? Technological advances in diagnosis have reached the shores of India. These advances are available for diagnosis of genetic disorders as well. Testing for genetic disorders requires significant input from genetic counselors. However, socioeconomic and cultural issues have not changed. Genetic counselors will encounter these socioeconomic and cultural issues that are not frequently encountered in other countries. Genetic counselors have to be sensitive to these socioeconomic and cultural aspects. There are a number of issues that need to be addressed so that genetic counseling is beneficial for patients and families in India. They include need for more trained clinical geneticists and genetic counselors, potential impediments to counseling due to the multitude of languages used in India, the role of consanguinity, a variety of cultural issues, and equity. There is an increase in the number of families and patients that need genetic counseling. This increase will only continue. The number of trained clinicians and genetic counselors are inadequate to meet the increased needs. Prevention or early diagnosis may be the only options available for many genetic disorders. Hence, it is important to equip physicians in all subspecialties with knowledge required to alert them to the genetic basis of conditions that they may encounter. There is also need to train genetic counselors as faculty who can help develop additional training programs. Language is an important component of communication in genetic counseling. There are 22 scheduled languages in the Indian Constitution as shown here. Each state shown in this map will have populations that speak a different language. Only a proportion of the population can communicate in English. When it comes to languages, India is like Europe. Language is important for many aspects of genetic counseling. They include for obtaining family history, for obtaining medical history, for conveying recurrence risk, and for explaining clinical and management issues. How can this language barrier be overcome so that genetic counseling is beneficial to many and not just a few? Developing genetic counseling training programs in the different states where different languages are used can help. Developing the required vocabulary in the various languages is also important. Clinicians, social scientists, and linguists can be valuable resources to develop the required vocabulary. The prevalence of consanguinity is significant in India compared to many countries. In different regions and communities, the prevalence of consanguineous marriages can range anywhere from 10% to 47%. How does the prevalence of consanguinity impact genetic counseling in India? Practitioners of genetic counseling in India may have some strategies for this. This is something that genetic counselors trained in other countries may not be adequately trained in, but this is absolutely essential for genetic counseling in India. With economic changes in India, there may be some changes to the prevalence of consanguinity. However, these changes may not be significant and uniform across the country. Consanguinity will continue to be an issue that is different from what one would encounter during genetic counseling in other countries. In genetic counseling, allele frequencies are essential information for providing risk figures when testing options are not available. Detailed counseling can help the patient and family make informed decisions. Counseling can also help in aiding in collecting important information for future counseling of members in the community by contributing to databases. Genetic counselors are in a unique position to contribute towards this goal. Laboratories performing molecular diagnostics in India can also help in developing and contributing towards well-curated databases. A serious consequence of a genetic diagnosis is the potential for stigma following the diagnosis. Confidentiality and privacy protection are important in genetic counseling. How does one navigate these issues in India? If a treatment is not available, the options for families at risk for a genetic disorder are counseling of extended family members, carrier testing, prenatal diagnosis, and the use of donor gametes. These options are used regularly in other countries. In India, some of these options may not be available. Others may not be culturally acceptable. What are the cultural barriers to options such as the use of donor gametes in India? Equity is another issue in a country like India that needs to be addressed. are the various aspects related to genetic disorders accessible to all, including access to diagnosis, access to counseling, cost of testing, access to treatment and cost of treatment, and language barrier. Genetic counselors face these issues as part of counseling in every country. Genetic counselors in India will have to play a role in addressing these issues and help towards developing solutions with the help of government and private entities. As for the future of genetic counseling in India, there are a number of issues that need to be addressed. Some of these issues may be unique to India. The issues include significant socioeconomic differences that can impact access as well as the process of genetic counseling, language barrier that can impact effectiveness of genetic counseling, the need for additional training programs in the different states and regions of the country, need to train clinical geneticists, include genetics in physician training, availability and access to genetic data that can impact accuracy of the counseling process, and availability of resources for post-diagnostic management. There are ample research opportunities to study and help address these issues. There is interest amongst the younger generation to enter this field. As in any other field, it is important to develop guidelines for the profession, especially a young profession such as genetic counseling in India. The certification of genetic counselors in India is an important step in recognizing the profession of genetic counseling. It is also important to help develop career opportunities for the genetic counselors. This would involve encouraging clinicians to include genetic counselors as a member of their team in their clinical practice. To conclude, genetic counseling in India has come a long way since 1979. It has been fascinating to see the developments in clinical genetics and genetic counseling in India over the last 40 years. I would like to thank Dr. Annie Hassan for allowing me to be part of this exciting journey of training genetic counselors in India. I would also like to thank the organizers of Wellcome Connecting Science for inviting me to share my thoughts on genetic counseling in India. Please feel free to contact me if you would like to discuss further the topics I presented on genetic counseling in India. Thank you.
Hi everyone, my name is Sagira Sharif. I'm one of the principal genetic counselors at Leeds in UK. I'm grateful for the organizing committee for giving me an opportunity to present my competency framework. This framework is developed with the help of my supervisor from University of South Wales in the UK and Yorkshire Regional Genetic Service. In this presentation, I'm outlining the rationale of this framework and highlighting why diversity is important in genomics and how a healthcare professional and health organization play their role in enhancing this inclusion. As we all know, there are clinical and scientific imperative of diversity in genomics. The genomic variation that exists across population can greatly affect the genetic analysis of the disease and complex trait. And therefore, interpretation is important in enhancing our understanding about the biological aspect of the disease. It supports the genetic diagnosis and offer informed reproductive choices. It guides pharmacogenomic pathways and other clinical pathways for the common diseases. It is therefore important that our genomic databases are reflective of diversity And so that genomic advances are maximized for our diverse population. As we know from our experience with the COVID-19 pandemic, that the disproportionate impact has on the ethnic minority has highlighted that it's important that diverse communities are involved in genomic studies. Despite this, lack of diversity in genomic is a global concern, as 88 to 90% of genomic studies have focused on European ancestry, which is approximately 16% of the global population. This lack of inclusion is highlighting the major clinical, moral, and scientific challenge, as this restricts the clinical utility of the genomic advances and impact health outcomes. On a local level at Yorkshire, we serve 4 million of population. Out of that, British Pakistani population is the largest ethnic group in Yorkshire. We know that the autosomal recessive condition are common in this population because of their cultural practice of consanguinity and endogamy. Therefore, it's important that these families are involved in genomic studies. However, a recent deciphering development disorder study in the UK, which utilized exome sequencing to identify the molecular basis for developmental disorder in approximately 13,500 children with the trio sample from their parents, have identified the diagnostic yield approximately 40%. However, Pakistani population, as you can see, mostly Asian Pakistani population, there was low uptake of this study. It's important to understand that consanguinity is important, not just in genomic study, not that because it provides diagnosis for the family, but it helps scientific knowledge as well, as we identified new genes, and it is helpful for proving pathogenicity of a specific genomic variant. One potential hypothesis is that the low level of this uptake was due to lack of culturally competent approach to this population. Literature shows, our own practice at Yorkshire shows that there are a number of ethical, social, cultural, and religious barriers. It's important to understand these barriers, as often we label these communities as hard to reach or underrepresented. For me, I believe that they are underserved, that community, underserved population, and we need to develop a specific communication strategy to make sure that they are involved in the genomic studies. Culturally competent genomic care, this concept is very well established at Yorkshire because of our rich diversity of population in Yorkshire. There are multiple definitions of culturally competent care are available. For me, it is the ability of an individual healthcare and organization to effectively deliver services that meet the client cultural and communication needs. As we all know, equity of access and reducing health disparities are the key area of focus of the health organization. So provision of culturally competent genomic care should be a priority. My own approach of culturally competent provision of service at Yorkshire has significantly improved access to genomic for this population. Over the year, I have been involved in 3 large cohort of British Pakistani family with a recessive disorder in genomic studies, and have collected a large number of families with the affected and unaffected children and other relatives. This research has identified 35 autosomal recessive gene, publication in 60 high profile journal, and empowered family to make an informed decision in regard to reproductive option and carrier testing. We've also been involved in a psychosocial study where we have collected families, and this has enhanced our understanding toward their attitude toward prenatal diagnosis and termination of pregnancy. I wanted to use that experience with the British Pakistani families and to see, to critically analyze my approach and see identify the core concept of why this engagement was successful. So I've used the call model of reflection for my PhD studies. The first 2 stages of this model has helped me to identify the key factor and the context in which these consultation happen. And the abstract conceptualization stage helped me to categorize those factors which help me to engage those Pakistani community in these studies. This was categorized as my clinical knowledge, my genomic knowledge, my cultural awareness of this population, and my research skill. At the fourth stage of this model, I decided to apply this theoretical knowledge to inform a new framework. And I have developed this framework of culturally competent care. This framework comprises 3 core concepts: cultural competency, genomic competency, and research competency. As you can see, the area of overlap between of these core competency ensures safe, ethical, and effective clinical practice. It's important to understand that arranging culture competency is not just arranging the interpreter for the community who don't speak English or their first language is not English. It's important as a healthcare professional and as a healthcare organization that we understand the structure of our population, we understand the diverse population structure, we understand their values, their belief, and how that influence their decision making. Same as the genomic competency is the ability of a healthcare professional to understand the complex genomic complex scientific concept and translate that into clinical practice. So it's important that the layer of competency, they overlap each other. And as we know that none of these competencies are practiced in isolation. They are heavily relying on our communication. So the effective communication is the central concept of this framework in which all 3 competencies are embedded. Healthcare system play an important role within this framework as developing culturally competent strategies, culturally competent workforce, and provision of genomic education and culturally competent training for healthcare professionals. This framework has been published, and I will encourage you all to read this, please, and see if you can implement that in your local training programs. As we know that there are phases of clinical genomic testing, so the level of competencies is varied from one phase to another. Therefore, we have divided the core competency into sub competency statement. Practice indicators are provided so that the gap in training are identified, and further the objective learning objective are developed. It's important that we all work together in this and make sure that the culture competent training is reflective in our clinical practice and in our training curriculum and educational curriculum. Therefore, a shared global vision is required. I will request all the leaders on this conference to please develop policies that ensure that culture competency is embedded in training. Together we can make this possible. Thank you very much for listening.
Great, thanks. Hello and welcome back, everyone. So I hope you enjoyed that session as much as I did. We've got a lovely treat now, which is that we get to have a bit of a discussion. So if you haven't already used the chat box in the portal there to put in your questions, it's okay, it's not too late. Please do so whenever you like. And as we talk as well together, I'm anticipating that, you know, maybe for some of you that will trigger additional questions that you hadn't thought of as our speakers were presenting. So as things come to you, please do just keep putting them into the Q&A box, and we'll keep an eye on it and see how many questions we can get through. So first thing I'd like to do is just thank you all so much, because that was just, I mean, hopefully we'll get there, but it felt to me like there were some real common elements between all of the things that you were talking about, despite the fact that you're talking about genetic counselling in very different environments and locations. So that was really interesting to see. So yeah, I'm going to pose some questions that we've been given. to individuals within this group. But if anybody else to whom the question was not directly addressed has something that they'd like to say, please do feel free to jump in and add your thoughts as well. Okay, so I'm going to start at the top of my question list, and the first one here seems to be for Clara. So it sounds like you're saying that it's important to position genetic counselling, or to frame it in terms of how it meets the needs of those whose support you're seeking. And I know this kind of work, writing business cases, etc., is super intimidating to people. So can you tell us more about how you determine what the priorities or needs are of the policymakers who support you're seeking?
Yeah, it's an excellent question, and is super intimidating, and talking to people in government can be super intimidating. When I first started doing this for our business case, Christmas year before last, it was every meeting I dreaded and was worried about how it was going to go. But we've done a lot of homework. So I think there's a number of steps, I would say. So the first one is the government at least look at the documents that they're putting out, the government's policy statements, their roadmaps, their press releases, particularly the ones if you're targeting to the Department of Health, particularly look at press releases that are coming from the Department of Health and documents from there. What are they saying is important? Like, how are they framing things? And you start to see some commonalities across that. The second is using your genetic counselling skills, doing homework, talking to people. That might be people that you might know that sit on committees with government, or talking to government bureaucrats, government public servants, and asking them, it's really tempting to always go straight in and do the pitch and, this is what we're after. But before you kind of get to that stage, or even while you're preparing the business case, talking to people and finding out what their priorities are, what they're working on, what's important to government, is really helpful, so that when you're writing the business case, you can frame it in that way. And when you're talking to them, you can come from that place as well. Certainly, I found with the minister's offices, there wasn't time necessarily to explore that. They're quite short windows, and I did need to go more into the pitch, but also listen carefully to the questions they were asking and be able to be adept at responding accordingly. But because we've done our homework, that worked. The other thing is not possible for everybody, but it was really important for us. If you have the funding, there are people that will, advisors that you can pay, government relation advisors who can help you do that. And that was certainly in our case really helpful. If you have a lot of money, which we did not, and ethically it seems okay, then some people employ lobbyists. And I know some of the people in areas, not genetic counselling, but in other areas that were putting business cases in at the same time, employed lobbyists who are the ones that then make the contact and put the case initially and organise for you to meet the government people. Because we were publicly funded, that didn't feel right to spend money that we were getting in government for lobbyists to lobby government. So we didn't do that at all. So there's sort of a range, there's a scope there depending on the budget available to you. I think it actually made a difference. The feedback we had was that it made a difference that we were the ones contacting government, contacting the public servants, talking to them directly. That was noticed very positively.
Okay, no, that's really great. I think additional sort of context and understanding perhaps for people to have. So thank you for that. Charlotta, there's a question for you here, which is about how important has support from your medical geneticist colleagues been for the development of the genetic counselling profession in Sweden?
I think it's been very, very important. And I would say it has been important from several aspects, I would say. So one aspect, of course, to find, as before, it was a clinical geneticist who did the genetic counselling. I think one thing is to find the right doctors that believe in the profession. So that is one thing, and to go with them. And the other thing I thought about when I saw this question was also that I think when we came out from the first program, we were so enthusiastic, but maybe we were a little bit, I don't know if you can say too enthusiastic, but I think we were saying like, well, we can do what the doctors can do. We can give counseling as the doctors can. And then it becomes more like a clinch. So I think you need to find a collaboration between a clinical geneticist and yourself. And again, which I stated in the presentation as well, I think the main key here is to create trust, to build it together. So find someone that believes in the profession per se, but also create personal trust with someone, and that can expand to other colleagues, both within the clinical geneticist and other genetic counselors. So I think personal relationship in a way is a crucial way to start.
Yeah, beautiful. Yeah, so it sounds to me like you're talking, the word that comes into my mind is champions, to find champions that are willing to work with you on it. Just wanted to run that by Rebecca as well. Anything that you wanted to add on that at all?
No, I agree with Lotta at the medical geneticists have really been crucial in our journey here. And we found lots of support there with our colleagues on many different levels. Definitely.
Wonderful. Yeah, and I, speaking as a genetic counselor who's based in North America, I imagine that I can anticipate what the underlying sort of reasoning for this question is. For those of you who are not aware, in North America, well, in the US specifically, there's a bill that's been presented about allowing genetic counselors to be independent providers under Medicare, which is not being supported by the American College of Medical Genetics and Genomics, which has been caused quite some fractiousness, I'm going to say, within the clinical genetics community. So that's been a thing. Anyway,
can I just add to that a very short question, because in the beginning that was the same thing. We had a lot of discussions when we were creating this educational pathway, if or not we could work independently. That word was a word that was really discussed for a long time. But again, you need to create trust.
Yep,
slowly
absolutely.
And build it.
Yeah. No, thank you for that. That's beautiful. Okay.
And also showing the clinicians involved that you really add value to their practice and to what the patients are. It's a long, just describing the whole thing is time consuming. And in the US, how long, people don't have time for that. The physicians don't have time for that. And this is the same thing in India. They need to embrace the profession of genetic counselors and their teams.
Completely agree, Maya. I've got a question for you actually next, as it happens. So could you tell us more about the translation of genetics into the different languages used in India? What's the difference between literal translation and cultural translation of words like DNA?
Yeah, I do not think they exist right now, but I know that the program that Annie Hassan has, she takes in students from different parts of the country. But when it goes back to what they are conveying to the patients, I am not sure people have done studies to see how exactly it is done. Are there words for it? Or do they show them pictures? I remember in the good old days, we used to have pictures to show our patients. This is what a DNA looks like. This is what chromosomes look like. And this is what non-disjunction looks like. And this is what trisomy 21 looks like. One has to start with that kind of, at that level when you're trying to convey the information in a country like India, where there is such disparity in the educational background of the patients that you encounter. Yeah, so I think to start with, it's got to be pictorial rather than coming up with words, but that is important eventually, I would think.
Yeah, I have some very, very limited experience with this myself. I did some work years ago about trying to sort of help some physicians in China with talking with families about genetics of psychiatric disorders. And that became tricky because we realized very quickly that there wasn't a word or a way of talking about psychosis. Psychosis isn't a thing, apparently. So trying to figure out like how you would actually convey that concept. It was very, very interesting process. So no, thank you for that, Maya. Yeah.
And I agree with Maya. And we did in UK, we did some translation of a leaflet long time ago. And my colleagues have looked at Mushtaq Ahmad. He one of our senior genetic counselor, recently retired, and he has worked with one of the social scientists, and they looked at all the translation of all these scientific concepts. And it was interesting, Maya, that the word in Urdu language was even more confusing for our Pakistani speaking or Urdu speaking patient than just simply using the DNA. They were much more familiar with the word DNA and gene rather than the word which is called hulia, which didn't make any sense to them. So the translation is not as easy.
Yeah,
Right.
I wonder whether this is a function of the new information age, where people are reading all these words. I mean, they see these words, so they kind of know. So it's just a matter of educating them on the science behind it and the visual behind it. That makes it easy for them. You know, they know the word DNA, but show them what DNA looks like. They know what chromosomes are, show them what a chromosome looks like. And I think that should serve to help them. Yes.
No, I agree. I think it's a great place to start for sure. Yeah. And no, thank you for that contribution as well, Sagira. I think that's great. I do actually have a specific question for you though, if you don't mind.
Yeah, of course.
So Sagira, can you tell us more about how you explain the relevance or significance from a genetics point of view of consanguinity to families?
I think that is kind of a very overpowering kind of the way you speak with the family, because if you look at from the family prospect, there is a lot of studies out there that consanguineous families feel blame. There's a lot of hype in media as well. So the moment you mention cousin marriage, the distrust is there. They're not gonna, because they believe that if there are 4 brothers, they marry with the 4 cousins and only one of them has affected children, it's very difficult from the family point of view to understand what message we are trying to convey. So when I speak with the family, I don't say that this happened because if it's cousin. I start with the message that we all are a carrier of something.
Yes.
And I am a carrier of something. My husband is a carrier of something. And regardless of where we come from, who we are, we do carry some gene which may be not working in our systems. However, when you are related, because if you look at you've got common ancestor and there is a common genetic pool, there is a higher chance that what you carry, your husband will carry the same. Whereas if say I'm not related to my husband, the chances of that what he carry, I may not carry that.
Yeah.
And when there are 2 carriers, then there is a risk of having a child with that same genetic problem or fault or mutation or variant, which increases the burden of autosomal recessive condition. And that's what has happened. And I use my hands as well. I talk a lot with my hands as well, but I make a diagram as well. I show them with exactly with the diagram that this is you and this is your husband. This is how so I use picture as well, but I use my own. And how is that clinically significant? What is the impact there? And why this has happened, and why your sister who's married with your husband, brother, why they don't have affected children with that? That they may be a carrier, or they may every time when they are having a child, maybe they're passing the normal gene, and it's just nature is playing that trick there. So they may not have that. So I think that I think that this helps you to establish a better therapeutic relationship with your patient. But if I start with that message, sometimes we receive a referral from healthcare professional and there's no family history apart from their first cousin. So I think that is kind of the debates in the media, they feel that we are after their cultural practice. And there is an issue of kind of forced marriages and versus cousin marriages, where these are completely different scenarios. There are political aspect on one side. So it just overlaps these kind of messages. So I think instead of emphasizing the word cousin, I will emphasize the word carrier, and how 2 carrier, regardless of wherever they are, for cystic fibrosis in Caucasian families. Tay-Sachs, for why it is a high risk of Tay-Sachs in Ashkenazi families who are not first cousin. And then there is a genetic isolate communities as well. So where are you coming from? And like, for example, it's not just the consanguinity, endogamy as well, where they are marrying within their tribe as well. So how that contribute when when you stay kind of in one of the isolated kind of genetically isolated population, how there's not further genetic pool is mixing here. So it's the same genetic pool, you are practicing that marriage practice. So it is a higher chance that even if you're not related, but you belong to the same network of your brotherly system, caste system, tribe system, that genetic disorder will be more prevalent in that groups.
So Anna had a really interesting observation just in the little chat box here, and she was pointing out, I think she's spot on. It's a lovely way of articulating it. I think that her observation of what you were saying, Sagira, is that, you know, if there's any blame to be attributed anywhere here, it's on the genes themselves rather than the consanguinity kind of thing.
Absolutely, absolutely. It's the genetic variation which we carry. It's not the cousin that because we cousin and it happened.
Yeah, exactly. That's beautiful. Lovely. Thank you. That's great. Okay, so I'm going to go back to a question for Clara. Although actually, you know what? I think this is actually sort of relevant to Rebecca and Charlotta as well. And it's about for countries who don't have a professional body of genetic counsellors yet. Actually, it's kind of relevant to everyone, isn't it, really? Would you advise that local genetic counsellors just join together to set up the professional body themselves? Jump in, anyone.
I'd say yes, absolutely. I think that was really pivotal event in Australia where the genetic counsellors sort of, I can't remember the exact year, but I think it was like early 1990s, maybe around 1992, when the small group of genetic counsellors that were working at the moment had an informal meeting and decided to form a group. And that body, the Australian Society of Genetic Counsellors, has gone from strength to strength. First of all, in defining the scope of practice and a whole range of things, and now advocating for funding with government. In our case, and this sort of relates a little bit to that question to Charlotte earlier about the importance of medical geneticist colleagues. The Australian Society of, Australasian Society, it includes New Zealand as well, was formed as a special interest group of the Human Genetics Society of Australasia. So we are a special interest group within a larger body of professionals. We're actually the largest special interest group within that, but it includes medical geneticists and the laboratory, the medical scientists, clinical scientists as well, and the biochemists. There's a number of special interest groups, and that's been a strength for us as well, being able to work with our colleagues working in genetics. And we have, so as I was saying, with the funding now, seeking funding from national government, we have the support of our colleagues, and it's that overarching body, the HGSA, that are putting in the submission. So it's been very beneficial for us to do that rather than setting up separately. There are pros and cons, but rather than setting up separately and being a very small group, having to do everything ourselves, it's been very beneficial working within that larger group.
Beautiful, thank you.
Yeah, Janine, I just want to add here as well that in Pakistan, the genetic services are not established, and I'm from Pakistani origin myself. There are, I just want to appreciate the work of my colleague from United States, Aisha Kurban, maybe in the audience listening to us, one of the genetic counselor. She has set up a group of other genetic counselors from United States, and they worked with myself as well and invited me as well from the UK as well. And they have in one of the largest city in Pakistan, in Karachi, they've been in touch with with one of the university, and in Lahore as well, and delivering some genetic counseling as we all are as a group taking up some of the activity, which is over and top of our clinical commitment in our own countries as well, where we are practicing. So it is kind of creating an awareness, and that awareness and bringing the clinical community to help us to see that there is a need for this service, and to speak and creating a genetic awareness amongst population as well. So we are planning to discuss that on the health policy level as well. So the plan is in place. I have discussed with the genomic education program in the UK as well, that how can they support this for underdeveloping country or emerging economy as well, that if we want to deliver some genetic education program there as well. So we are trying and kind of making those government and making those health policy maker, those country to come and support us. And I'm sure that message is getting noted from all different parts. It is slow process, but hopefully we are very hopeful that it will take some step forward.
Yeah, that's great. And I've got a question about that for you all, hopefully at the end, about the slow process part that you just alluded to. But first, so Maya, question for you. Do graduates of India's genetic counselling programs find positions to practice in? Is there a deficit of genetic counsellors for the needs across the country, would you say?
There is a huge deficit. As for employment, I believe they are getting employed. And, there are different places where they're getting employed. Many are joining companies, diagnostic companies.
Yeah.
And I think the numbers that are going into those at the company levels are probably higher. I don't have the statistics, but I think that is where most of them are getting employed because they do need them. It's still a challenge to get the clinicians to understand the need for having genetic counselors in their team. And this is where the physicians really need to know that genetics contributes to a certain number of the disorders that they see. And empowering the patients and families with the information is absolutely critical. And there is a group of trained people who can explain it to the patients and families so that they can be empowered with the information and make the right decisions.
Yeah.
So yes, they are getting, there's a big deficit because, as you know, the size of the country, and that's why it's important to have additional training programs.
Mm-hmm.
And when you have these training programs, you might as well have them in the different states, because each of those states are huge.
Yeah.
And if you have them in those states, you can also train them to their language, their cultural issues and everything. Each state is culturally different as well. The educational status in many of these states are different from one another. The numbers, the proportion of people who are educated, who can understand English is different in the different states. So it's a fascinating country to study these kind of issues and see how you can come up with solutions. But yes, there's a deficit. And as I said, there's great interest among the younger generation to enter the profession. And you need to be careful, though, in how you bring these individuals into the profession, because why are they coming in? Are they coming in because of the science? Or because they want to help the people? There are different reasons why people come in. I mean, you need a combination of all of them, but you need to have people of different interests coming into the field as well.
Yeah, beautiful, thank you. Okay, we've only got a few minutes left, so I'd actually like to make sure we've got time for what I think is one of the most important questions for all of you, every single one of you here. Are you ready for the most important question?
We're ready.
So I'd written the same question, but in different words, and mine was a lot blunter. So I'm going to use the one that somebody else put in the Q&A box because it's more beautifully framed than mine. So the question writer says, as pioneers, you are pushing boundaries, but it can obviously be very demanding as an individual. How do you keep boundaries to protect yourselves in this process? And I think that's just, I think that's what puts, that's what's so intimidating to so many people. And I think we struggle with the experience of failure and, getting knockbacks and so on. And in all of the stories that you've presented so beautifully and eloquently today, you've presented the successes and you've touched on some of the failures, but there's a lot more failures than, for many of us, at least, personally speaking, that we don't often give airtime to. But they can be so painful, like the price you pay there is high. So what do you do, people? What do you do to take care of yourselves? How have you kept going, persevering through all of this?
I think the previous talks today earlier on supervision, for example, is one of those, at least the professional boundaries, and keeping a mindset that is still not too tough. And not just counseling supervision, but also this peer supervision that was touched on as well in that session. That's one of the ways to protect yourself in a harsh environment. But there's, I think, the difference also between the professional boundaries and then the private boundaries, because work can totally take over as well, and you need to take care of yourself on a private level as well.
Yeah, thank you, Rebecca. Anybody else want to go for it?
I mean, it depends, Janine, that what are the pressure, and depending upon what are they clinical pressure, are they research pressure, are they management pressure, or is it team dynamics? What kind of the pressure? Because I believe personally that if you are clinically competent and genomically competent, you can survive no matter the amount of the clinical burden or the patient difficult kind of the, because now there's a lot of clinical burden. Like for example, we've started prenatal exome testing last year in October, and I'm prenatal lead. So there are a lot of clinical pressures. There's a lot of challenging cases, and they do leave impact on you as well. But but at the end of the day, there is a sense of satisfaction as well from our jobs as well, that at least we have made some differences. We can't find a cure for someone, but at least whatever is available, either is a screening, either is a testing, or either is a carrier testing, prenatal testing, prenatal genetic diagnosis. We have empowered our patient to make an informed decision.
I think there are particular though, like burdens is what I'm going to call it, associated with leadership.
Yeah.
Right. So you're absolutely right, Sagira. I completely agree that the work that we all do as genetic counselors, no matter what it is, there's challenges associated with that. But I maybe I'm reading too much into this, but to me, this question is about, yes, acknowledge that for sure. But what you're all doing is that and more. Like it's that and more, because you're acting as leaders, and leadership is sometimes a lonely place to be, again speaking from bitter personal experience. So how do you like, what do you do with that, you know?
Yeah, I think you're right there, Janine, that it is, I mean, the ones that are leaders or pioneers or whatever you want to call them, this is not the only thing they do. They do the other things that other people also do, and you have that on top of it.
Yes.
And I think, as Rebecca said, I think to discuss with colleagues and peer supervision, because we don't have supervision in that formal way, but I think discussing both when it goes forward and backwards, and it's hard sometimes not to take it personally, but I think to discuss with other from different healthcare professionals to see, I think that's the most important part. To set the boundaries time-wise, I don't think that's our main advantage. I mean, we're not probably very good at that. So I think you need to find other boundaries, like talking to people.
Yeah.
And clinical supervision is on the top, isn't it, Janine? Clinical supervision, which we have, is on the top. But I feel that asking your colleague or peer for help and support, and making that aware of that you are struggling, so that they can have a better measure of that instead of just isolating and suffering, it's better to ask for help, not to shy to ask for help. That, look, I'm very busy, can you take some of this?
That's beautiful.
I think part of that as well, like you're talking about, seeking assistance from colleagues. I think in my position, I sort of see the leadership, it's a bit of an intermediary between government and the people that are going to be affected by the funding or not getting the funding. And me, it's communication again, but transparency and trying to keep people hopeful while also managing their expectations and boundaries around time. Like if somebody wants to meet with you while you're on leave, you're going to have to take that meeting, and I've had to do that. I don't like doing it, but I have to do it. But and at the same time, I know that might have been a completely wasted meeting. But I think it's much easier in retrospect, having done this for a while, to realise that when something doesn't work, it's not personal. It's not necessarily a failure on my part. it might be that the time wasn't right. Our first business case didn't get up. That was a failure, but actually, you know, it got up the next time, and what we put in the second time was much better. And in retrospect, I think it's good that we missed out the first time because we had a better case. The second time I've seen this with policy change in genetic counselling in Australia, you know, awards, you know, now with the Medicare funding, the government environment and policy environment is changing, which means there are new opportunities and things that haven't worked before might work now. So I think part of that resilience is keep not taking it too personally and not giving up, but looking, you know, keeping an eye and being able to look for a new opportunity to achieve what you want to achieve as well.
You know, I don't practice genetic counseling on a day-to-day basis, but as I said, in 1979, what I saw in India was what created the impression in me that you need to take something to the very end. So you make a diagnosis, but what more can you do for that family and patient? You know, what are the opportunities, even for a genetic counselor, to arrange for managing the issues that come up with them? So I have always thought about that. And that is one of the reasons why I started this interaction with Annie Hassan to see how we can make very, shall we say, an Indian model of genetic counseling, which is very unique to India with the given restrictions, but the need and the interest. There are youngsters who are interested in the field. There are families that need the help. And how do we bring all of that together? But take everything to the very end. I mean, I'm sitting here in the United States and comparing the situation in India with what families and patients can access in this country. You know, they have centers where patients with genetic disorders can get full services for any of the issues they need. How do you translate that in a developing country? You know, it's so hard, but you can just keep thinking and coming up with ideas and you know, discussing with somebody like Annie Hassan.
So I can see everybody's putting that, and I'm afraid
one comment to, yeah.
I can't. We were
Okay,
already.
no worry, just start speaking more.
What I'd like to do is encourage us to continue this conversation in spatial, because clearly there's still so much to say, and this is incredibly rich discussion. But I think now is the time for us to move it over to spatial. So with that, I'm just going to thank you all so very much. That was an incredibly inspiring session, and thank you all so much for your contributions today. It was really great.
Thank you very much.
Please join us in
Thank
spatial.
you.
Okay, bye.